This week on the BackTable Podcast.
They are essentially antibodies that are engineered to carry little chemotherapy particles directly into cancer cells. And they do that by being engineered to bind to specific antigens on cancer cells. And what we're seeing right now with our antibody-drug conjugates that are in development, usually the chemotherapy particle that is attached to them is a type of drug called a topoisomerase inhibitor, which as oncologists, we're all really familiar with our topoisomerase inhibitors as chemotherapies. And we have a few different targets that these antibody-drug conjugates are engineered to bind to as a way to deliver chemotherapy directly into the cancer cells.
Welcome to BackTable Tumor Board. I'm Dr. Kate Baker, medical oncologist and medical director of value-based care at Tennessee Oncology. I'm here today with Dr. Sara Nunnery, and we're very excited to talk about antibody-drug conjugates and breast cancer. Dr. Nunnery, do you want to introduce yourself and your role?
Yes. Hi, Kate. Thank you so much. I'm Dr. Sara Nunnery. I am a breast medical oncologist here at Tennessee Oncology based in the Nashville area, and I am the director of the breast cancer research program here. So I get to spend my time taking care of breast cancer patients and then also running all of our breast cancer trials here at Tennessee Oncology.
Well, perfect. Well, really excited to talk about this topic, antibody-drug conjugates, particularly in HER2-positive breast cancer today. Before we get into any cases or data, can you just walk us through at a high level how antibody-drug conjugates work and what makes them different from other therapies in breast cancer?
Absolutely. I think it's such an exciting time right now with these antibody-drug conjugates. There's so many in development. We now have 3 approvals in breast cancer. So the way that I like to explain antibody-drug conjugates to patients at a really high level is that they are essentially antibodies that are engineered to carry little chemotherapy particles directly into cancer cells. And they do that by being engineered to bind to specific antigens on cancer cells. And what we're seeing right now with our antibody-drug conjugates that are in development, usually the chemotherapy particle that is attached to them is a type of drug called a topoisomerase inhibitor, which as oncologists, we're all really familiar with our topoisomerase inhibitors as chemotherapies. And we have a few different targets that these antibody-drug conjugates are engineered to bind to as a way to deliver chemotherapy directly into the cancer cells. So really the goal with them is to have more targeted delivery of chemo to cancer, so be more potent in that way. But then also the hope is that because it's more targeted, we minimize some of those really traditional chemotherapy toxicities that come to mind when we think about chemotherapies. So it's really exciting to see the different engineering in the works with a lot of these drugs.
That's great. Thank you. That's a really straightforward, simple explanation. And that's often how I explain it to my patients as well. So I think that's something that even the layperson can understand. We're going to mainly focus on HER2-positive breast cancer today. And I know you see a lot of breast cancer. I see a lot of breast cancer. And maybe let's start by talking through a case recently that you've seen where you've started somebody on a HER2 antibody-drug conjugate.
Sure. Yeah. The HER2-positive breast cancer space right now is really exciting with a lot of new clinical trials that have just come out even in the last 3 months that are probably going to lead to new indications and approvals for antibody-drug conjugates. So it's a great topic to dive into today. I think I have 2 patient cases that are similar that come to mind that I've seen just in the last month that are relevant to a brand new approval that we have that I know we'll get into. But I think of a patient who was, around 60 years old. She was, young and otherwise healthy, who had presented with a really rapidly progressive change in her breast, just diffuse swelling and pain and erythema. And because of that presentation, there wasn't a really discrete mass per se. Like we see in oncology, sometimes that can lead to a bit of a delayed diagnosis when it's really just skin changes that are happening. And that was the case with this patient, unfortunately. But she really had noticed just rapidly progressive swelling of her breasts, skin thickening, redness. So ultimately was an inflammatory breast cancer at presentation. We were hopeful, that it would be just a localized inflammatory cancer that could be curable. But then, unfortunately, on staging, scans was found to have some pulmonary metastases, but thankfully no other distant mets. It was really just breast, axillary nodes, and pulmonary mets. We did biopsy the breast and also did a punch biopsy of the skin as well, which confirmed that it was a really high grade 3 with a high Ki-67 tumor. And it was ER negative, PR negative, and HER2 was strongly positive. It was 3+ by IHC, and then FISH came back strongly positive as well. So really a brand new diagnosis of metastatic HER2 positive breast cancer.
And so when you were first meeting this patient, I think historically we would have been using chemotherapy in combination with HER2-directed monoclonal antibodies. How did you think about the new data? And maybe let's get into that new Destiny trial that just came out. And how are we thinking about the paradigm shift in how we're treating a new diagnosis of metastatic breast cancer?
Yeah, so really the newest data that has been approved and led to an FDA approval is the data from Destiny Breast 09 that we actually saw back at ASCO. Destiny Breast 09 was really the first change in how we treat metastatic HER2-positive breast cancer in the first-line setting that we've had in years. The standard has long been the Cleopatra regimen, which is a taxane, typically docetaxel, combined with Herceptin Perjeta. And that's been our standard for the longest time. And so in Destiny Breast 09, they challenged that and randomized patients to receive first-line treatment with either T-DXd combined with pertuzumab versus that standard of care THP regimen. And really what they were trying to do by doing T-DXd combined with pertuzumab is to really maintain that dual HER2 blockade that we know led to better outcomes in the Cleopatra study. And so in that trial, they found a significant improvement in progression-free survival when patients were treated with T-DXd plus pertuzumab in the first line compared to our standard THP. By investigator assessment, it really doubled PFS. The standard in this trial, PFS in the control arm was 20 months. And by investigator assessment, the PFS in the T-DXd arm was 40 months. So really doubling PFS there. The data is still really immature, so we don't have overall survival data yet, but it's not surprising that we're already seeing a trend in improvement in overall survival with the T-DXd pertuzumab arm. And so we just got FDA approval in December 2025 to treat in the first-line metastatic setting HER2-positive disease with T-DXd plus pertuzumab. So that really is becoming our standard currently. And so this was actually one of the first patients that I was able to start on this new first-line therapy of T-DXd plus pertuzumab. So really exciting. I think one of the things that obviously comes to everyone's mind when we're using T-DXd is the concern about ILD.
ILD, yep.
Yeah. And so there's a lot of still debate in the field too, which it's not unwarranted, wondering, do we really need to use it in the first line? Can we not save it to rescue in the second line? In Destiny Breast 09, the ILD rates were really similar with what we've seen in all of the other Destiny Breast studies. It was right around 10-12% ILD rate. And thankfully, the grade 5 or those fatal ILD cases, it was less than 1%. Only a couple of patients had fatal ILD. But still, something that we all know as oncologists is so important to make sure we're watching out for those signs of ILD, because key is to catch it early and treat it early with steroids.
Yeah, for sure. Absolutely. And being careful about selection of patients as well, making sure if anybody has any history of other lung disease that you're counseling them carefully and being selective about the patients that you're choosing. We'll get into maybe some of the other toxicities of T-DXd compared to our traditional standard of care with docetaxel plus HPE. But Before we do that, I'd love to hear, since this is a relatively new regimen, how are you counseling? So this patient that you met with a new diagnosis of metastatic HER2 positive breast cancer, how are you counseling them about this regimen, its efficacy, and, potential toxicities like ILD?
Yeah, so definitely the ILD discussion is one that shouldn't be taken lightly. I think it's really important that we're counseling our patients on notifying providers about any new respiratory symptoms, any new shortness of breath, any new dry cough. And right along with that is making sure our nursing staff is aware as well. It'd be really easy for these patients to call in, and a triage team could easily just, say, well, it's a viral thing or nothing to be worried about. So I think educating both our patients and our staff to watch for these early symptoms and to make sure they don't slip through is so important. So the ILD is definitely something I always want to mention, that risk, but not to scare them, reassure them. It's about 10% of patients can experience that, and it's usually reversible and treatable when it's caught early, and that's our goal. Other things with T-DXd that I think we're all used to seeing is the fatigue. The fatigue can be very challenging for patients. So, monitoring energy levels is important. And then nausea as well can be a big problem for patients. Monitoring for cytopenias, of course, is still important. But I think the other kind of hot topic related to this is that with our Cleopatra THP regimen, we're all so used to, doing that sort of induction period of the taxane and then dropping it and doing just an HP maintenance. And so we're all wondering, can we do the same approach with our Enhertu pertuzumab first-line regimens? And if so, how are we going to do that? When do we stop it? And what maintenance do we switch to? And these are all questions that we do not know the answer to right now. So I think kind of my approach so far with talking with this patient, for example, and kind of going forward is I would love to still be able to switch to a maintenance approach for patients and give them that break from a cytotoxic therapy and a break for some of those toxicities. So I think trying to treat to a maximum response on scans, which might be different depending on the patients. Some patients might respond beautifully right off the bat, and then you see stable scans for a while. Others might keep responding for several months. So really trying to take it patient by patient and see how they are responding. And once we reach a point where it seems like their scans are stable, consider at that point switching to a maintenance type approach with just going to like a Phesgo, Herceptin, and Perjeta, and combining that with endocrine therapy with or without a CDK inhibitor, like the Patina regimen that we saw, if a patient's got hormone receptor positive disease as well. And then we also saw data in San Antonio from HER2 Climb 05, which was looking at adding tucatinib to Herceptin and Perjeta as a maintenance approach. So that could be a good option as well for patients who are hormone negative. So it's still something we are all trying to figure out. So we'll have to wait and see, as more data comes out, what's going to be the best approach for our patients going forward.
That's super helpful. I think I struggle with all of that as well in counseling my patients. So I'll be interested to see this additional data come out. Speaking of looking forward to additional data and the overall survival data from Destiny Breast 09, is there anything else in the metastatic HER2 positive space around antibody-drug conjugates that you're excited about? Potentially any HER2 ADCs in the pipeline that have a more favorable risk profile when it comes to ILD, or anything else that you're just looking forward to?
Yeah, such a great question, because we would all love to find the solution to this ILD. And I think it's such a big area of research. A lot of colleagues at other academic centers who are really focused on this topic and understanding it. There is another HER2-targeted ADC that's very similar to T-DXd that's currently in clinical trials, made by a company called Duality Bio in partnership with BioNTech. That is through the Dynasty breast trials, which we've seen some of that early phase data presented already. The large phase 3 study has just completed enrollment, so we'll all be anxiously awaiting for data from that study. So I think that's another HER2-targeted ADC that you're going to hear more about out and see more. We actually had the study open here at Tennessee Oncology. The early data with that drug did seem to suggest lower rates of ILD. So it was really exciting. I think we'll have to wait to see how that really pans out in a much larger phase 3 study. So we'll wait and see if any of these HER2-targeted ADCs that are coming, is there a way we can avoid that ILD? But I think we haven't quite exactly cracked the code into how to do that, and if it's really a class effect that we're going to see with all our HER2-targeted ADCs. So, but more to come for sure.
Sure, yeah, totally. And then related to the ILD, are there certain patient characteristics that make you more or less comfortable? I think we mentioned the lung disease and choosing the right patient, but is there a particular patient phenotype that you look out for that makes you think maybe this patient wouldn't tolerate a HER2-targeted ADC?
Yeah, no, I think you summarized it so well already. Just those patients with, underlying lung disease. Some, kind of looking at some composite data from earlier studies, data would suggest that patients who are older than 65, patients who have other comorbidities and especially renal disease might be more at risk of ILD. So definitely patients that are older with other comorbidities, I worry a little bit more about, but we all know it can happen to anyone and it can happen at any time. And I think we've seen from other studies, it can happen usually within the first year is when we see it, but it can happen late as well. So it's one of those things that we just can't ever let our guard down. But I think we are really now starting to push the envelope with ILD in terms of re-challenge and offering it to more patients. Approvals for T-DXd, we're seeing it. It's probably going to get approved in other settings as well for HER2-positive breast cancer. So we're only going to be seeing more of it. So really trying to get comfortable with it and better understand who is going to be more at risk, who could we safely re-challenge if they get a low-grade ILD. Definitely things that we're going to need to tease out more.
Yeah, that's so interesting that you mentioned re-challenging. I've not personally re-challenged a patient with a low-grade ILD in HER2, but would be interested if you have any experience with doing that, if you could share that with the audience.
Yeah, so I have not had anyone personally that I've re-challenged yet, but I will say I feel a little more reassured about re-challenging if it is a low grade, a grade 1 ILD. Hope Rugo and her team from UCSF had presented some data that we saw at ASCO and again, I think some updates at San Antonio, where they looked at a cohort of patients. It was all retrospective data, but that's really all we have at this point. But they looked at patients who had grade 1 ILD and their outcomes when they were re-challenged with T-DXd after a low-grade ILD. And really that retrospective data showed that most of those patients could be safely re-challenged with T-DXd after their grade 1 ILD was treated with steroids. It didn't seem to lead to any worse outcomes for those patients. So I think when the time comes, depending on the patient and how they're doing, I think if it's a case where someone was responding really well to T-DXd and they had a grade 1 ILD that resolved with steroids, I might feel more comfortable re-challenging now that we're seeing some of this data come out. So, but we're all waiting for definitely, more prospective data and larger cohorts to help guide those decisions.
Sure. And just so that everyone's clear on the grading of ILD, can you talk a little bit more about what grade 1 ILD looks like? Like, what are the criteria that you would look out for where a patient might be able to be safely re-challenged?
Yeah, and that's such an important piece to make sure people understand. So thanks for bringing that up. So grade 1 ILD is going to be asymptomatic. So it's only caught on their scans. That's really the key. So a patient who's doing fine, but on their restaging scans, we see a little hint of infiltrates or ground glass that the radiologist calls that could be concerning for ILD. So that would be a grade 1 situation where you would hold the Enhertu and treat with steroids, see if it resolves. And if it does resolve on their scans, could re-challenge at that point. Grade 2 is going to be really mild symptoms. So the patients that present with maybe a dry cough or a little bit of mild shortness of breath. There's only a few patients in the retrospective data that's been presented that were rechallenged after grade 2, and they seem to do okay. I'm not sure I would rechallenge after grade 2 at this point until we have more data, but really as long as the patient is asymptomatic, that would be grade 1 and could be someone that might be worth considering rechallenge.
Thanks. That's super helpful. Well, we'll see how the data evolves, but I think that's exciting, especially if somebody was responding really well to T-DXd, the potential that they could go back on the drug. Well, let's shift gears a little bit because you mentioned that we're going to be seeing more and more of these HER2-targeted ADCs in early stage breast cancer as well. And I know there was some recent data, the Destiny Breast 05 trial, I think, that has maybe shown that there's a role for ADCs in early stage HER2 positive breast cancer. I wonder if you have anybody that you've seen recently where you've thought about using it, or if the data is not quite mature yet. Would be interested to hear your thoughts.
Yes, Destiny Breast 05 was another one of those hot studies that was presented at ESMO. And in that study, they were randomizing patients to get treated in the adjuvant setting with T-DXd or T-DM1, which, is our current standard of care. I think the key for Destiny Breast 05 to really highlight and make sure people understand is these were really, really high-risk patients. So this study was for patients that had either completely inoperable, like inflammatory breast cancer at diagnosis, or patients that had residual disease in lymph nodes at the time of surgery. So these are not going to be, your T2 and 0 patients that had some residual disease, or your T3 and 1 that had a little bit of residual disease in the breast. And these are really high-risk patients that were enrolled. And so likewise, I would really only consider it for a really high-risk patient. The other thing, too, is that they did have cases of ILD that were fatal on the study. So they had a couple of grade 5 ILD cases on study. So always something to really consider and make sure you're watching for when you're in a curative intent setting. It would be such, a real tragedy to lose a patient that we're trying to cure from a toxicity. On the study, they monitored patients really closely with scans to watch for ILD. So that's something we're going to have to figure out how to implement in practice if we start treating patients routinely in the adjuvant setting. So I think we're definitely going to see this come to fruition and probably become standard of care for these really high-risk patients. But we'll definitely have to see how the approval pans out and how we're going to incorporate, monitoring our patients to make sure, we keep them safe while they're going through their curative intent treatment going forward.
Got it. And in that trial, did those patients receive standard of care TCHP up front before surgery, or what did that look like?
No, it's a great question. Yeah, most did have TCHP, and I can't remember the breakdown about if we had any AC THP as well. But yes, these were patients because they were so high risk that they were getting, more intense neoadjuvant regimens for sure.
Regimens. Okay, that makes sense. So just putting that all together for an early stage breast cancer, it sounds like this data is still a little bit immature, really only for high-risk patients and with extreme caution around the risk of ILD. I saw a patient recently with a 9-centimeter HER2-positive, ER/PR negative breast cancer with multiple matted nodes. Saw a surgeon who did not really think it was operable at this point. And we're considering doing TCHP for her. If she did not have a complete response, would that be somebody you would consider this T-DXd in the adjuvant setting?
Yeah, I think that's a great example of someone who's really high risk who would have enrolled on a trial like this. So absolutely.
Okay, that's a helpful way to think through it. I think there's even more ways that T-DXd is being now used, especially in the HER2-low, ultra-low space. And I think we have time to get into that as well, because I think this is another hot topic that is particularly relevant. So before we get into the data for using T-DXd in that space, how do you practically define HER2-low and HER2-ultralow? especially when you're out in the community. Our path labs are sort of all spread out. And what are the biggest challenges for HER2 status interpretation?
So I know that is such a good question that I feel like when the data came out, it really kind of rocked the pathology world. They hadn't had to think about HER2 in such a granular level. So I know the study was the DESTINY-Breast06 study, was really the first time that we saw a whole new concept of HER2-ultralow introduced. And I know there's so many DESTINY-Breast studies at this point, it's hard to keep all the numbers straight. But DB06 was really the first study that used T-DXd in patients that were HER2-low and in patients that were HER2-ultralow. The way that they define that is HER2-low are those patients that are IHC 1+ or 2+, and FISH negative if they're 2+. And HER2-ultralow are going to be those patients that score IHC 0, but actually do have a bit of faint HER2 staining. And if you look at the pathology guidelines, they actually have a distinction when you're calling something IHC 0. It can be IHC 0 with 0% staining, so nothing at all, or it can be IHC 0, but it have up to 10% staining of HER2, and that would still be classified as IHC 0. And so for this trial, they enrolled those patients that were IHC 0, but stained in that 1 to 10% range, and called it this new term of HER2-ultralow. And what the other piece of the DESTINY-Breast06 study, in addition to creating this idea of HER2-ultralow, was it was also the first time we saw an antibody-drug conjugate get used directly after endocrine therapy before patients get any chemotherapy. So DESTINY-Breast06 was kind of groundbreaking for two reasons, this HER2-ultralow piece, but then also moving in HER2 up earlier to be used right after progression on endocrine therapy. And the study did show that when patients who were HER2-low or ultra-low, they both had a benefit to being treated with T-DXd over our standard of care chemotherapy, predominantly capecitabine and taxanes, paclitaxel were kind of the chemos of physician's choice that were used most in that study. But using T-DXd improved progression-free survival by about 5 months for both patients who were HER2-low and HER2-ultralow. And so that's really what led to the approval that allows us to now use T-DXd once a patient is no longer fit for endocrine therapy. And so T-DXd is the only antibody-drug conjugate right now for HR-positive metastatic breast cancer that can be used earliest right after endocrine therapy, which is another kind of unique thing about that drug.
Yeah, I know you've done a lot of education with our pathology centers around HER2-ultralow status. What has that looked like? How has communication with our pathology labs been?
I think it's gone really well. Our pathologists are, they want to get the best care for patients too, and make sure, if a patient can qualify for a drug, they want to make sure they're reporting it properly. So my experience has been our pathologists are really, they want to help and want to report and make sure they're making it easy for us. I think there's still a lot of, pathology groups out in the community that aren't reporting it. And so I think we still have a way to go to really standardize how we report it. And then right now, too, we have so many patients that, their pathology when they were diagnosed with metastatic disease, it was from years ago, or obviously we weren't reporting this. So I'm sure you do, too. Spend a lot of time on the phone with the pathologist calling, asking, do you still have slides where you can go back and look for me and see, is there any staining at all that would qualify patients? And if not, the question comes up, do we need to rebiopsy patients to check for it? So hopefully, though, in the future, we'll see it become a little more standardized. So I don't know I know we both kind of practice in a little different areas in Tennessee. What have you been seeing in your area, Kate?
Yeah, I think a similar experience, especially with patients with older pathology. I find I'm more frequently having to rebiopsy just to make sure we're getting that HER2 ultra-low status and covering all our bases, especially as these are being sequenced into earlier lines of treatment for metastatic HER2-low and ultra-low breast cancer. So,
yeah.
Speaking of sequencing, obviously first line for HR-positive HER2-low, HER2-ultralow is endocrine therapy and a CDK4/6 inhibitors. But after that, if after progression on that, how are you sequencing these HER2 ADCs compared to the never-ending list of alternative options for patients with metastatic breast cancer? And what patients are ideal for these HER2 ADCs?
No, it's so different for our hormone receptor positive patients compared to our true HER2 positive patients, because our true HER2 positive patients, they're used to IV treatment, from the very beginning. So it's not as big of a leap as opposed to our hormone receptor positive patients. The majority of their early years of treatment are all on just oral medication. So making that leap from an oral medicine to now an IV antibody-drug conjugate is not a small one for most patients, understandably. So I still always want to maximize as many number of lines of endocrine therapy as possible. I think we all, the more you practice, the more you get a sense of when someone's disease is becoming what we call endocrine resistant and not going to respond well anymore to an endocrine-based therapy. And that's so variable depending on the patient. So definitely someone who responds well on first-line therapy for generally 12 months or longer. I like to try more lines of endocrine therapy before considering something like an antibody-drug conjugate. We certainly see those patients that they progress really rapidly on their first-line therapy, and that we know is just in a more aggressive disease biology. And those are patients where, I would consider going to an antibody-drug conjugate right in the second line if it seems like they're not going to respond to endocrine therapy anymore. I think it's definitely still a conversation for our patients who have more indolent disease. We all see those patients that they've been on endocrine therapy multiple lines and their disease is, maybe it's bone only and it's, slowly progresses, still making that leap from an endocrine therapy to, again, an IV treatment that requires a port and it, can lead to hair loss and have toxicities. It can be tough when we have another oral option like capecitabine available. So I don't think it's unreasonable for those types of patients to have the discussion about, what's within their goals. Do they want to try another oral option like capecitabine first, or do they want to go to T-DXd? Destiny Breast will tell us that T-DXd outperforms capecitabine in that setting, but it's part of the art of medicine is treating our patient, what their goals are.
Sure.
So I still think it's a conversation to be had to see if patients are ready to make that leap or not, because we all see those patients that will say, I'm not ready for that. Even if it means I might progress a little sooner, I'm fine with doing capecitabine first. So that's really kind of my approach. Unless someone's disease is really, seems like, the pace of it's progressing more quickly and becoming more aggressive, I think it could still be a conversation about, capecitabine or another IV therapy versus going to T-DXd.
No, I think that makes a lot of sense. I mean, we're very lucky in breast cancer treatment that we have so many options, especially in the hormone positive HER2-low, HER2-ultralow space. So there are a lot of those options. And I agree with you. I think that's just the art of medicine, is figuring out how to sequence the right treatment for the right patient at the right time. Well, I'd love to hear what you're looking forward to. I think we already sort of talked about this in the HER2 positive space, but is there anything in the HER2-low, ultra-low space where you think the data is going to go with HER2 ADCs? Will we see that alternative HER2 ADC with less ILD being studied in that space? What do you think?
No, I think we're just scratching the surface, and we're going to see more of them coming into the HER2-low, HER2-ultralow space. There's thought, what about just the HER2-zero patients altogether? Could they still respond? So we'll see what happens. I think We're also looking at a lot of new targets as well for both really all types of breast cancer. We've got our other TROP2 targeted ADCs. We're also seeing HER3 targeted ADCs in clinical trials right now, especially in hormone receptor positive disease. There's thought that kind of signaling through the HER3 pathway might play a role in endocrine resistance. So I think that's a new target that we're going to see more of for definitely our patients with hormone receptor positive disease, and we'll see about other areas. But we're also, of course, kind of the big thing that you probably know more about than me at this point, since you treat malignant heme as well, but we're seeing bispecifics come into play for our breast cancer patients, targeting more than one antigen at once. So we'll see what comes with some of those studies as well. There's so many in development right now that I'm excited to see what pans out and starts moving forward into bigger trials.
That's awesome. Yeah, bispecifics are becoming huge in solid tumor. So I'm sure breast cancer is next for sure.
Yes, absolutely.
Well, any other practical tips you can leave our audience with about the HER2 antibody-drug conjugates, T-DXd?
Yeah, no, I think one other thing that's worth mentioning, and this is probably not a tip, but hopefully doesn't confuse people more, but it's the reality of the field right now is, we also saw data at ESMO for using T-DXd in the neoadjuvant setting, and that was the Destiny Breast 11 study. So similar high-risk patient population as like DB05. These were patients, again, these are not going to be your T2 and 0 HER2 positive patients. These were T3 and higher, or, at least positive lymph nodes. And in that study, they randomized patients to get T-DXd times 4 cycles, followed by THP times 4 cycles. And that was compared to an AC THP control arm. So a little bit of controversy over, that control arm. But again, it was high-risk patients. And they saw a really significant improvement in path-CR rate with that neoadjuvant T-DXd regimen. So the big question is, what are we going to do we give patients T-DXd neoadjuvantly and adjuvantly, and then again in the first-line metastatic setting when they recur?
That just sounds like a way to give people ILD.
Exactly, I know. So I think it's really exciting to see all of these studies be so impactful in terms of positive results. But then the practicality of it comes into play. How are we going to implement this into practice? Because obviously we know we can't give everybody T-DXd for every single line of therapy. So just things to be aware of. I think you're going to see a lot of debate. It's going to be a really hot topic in terms of how are we going to implement this into practice. But I think we already do have that approval for DB09. That's the first line metastatic setting. We'll wait and see later this year. We have some PDUFA dates coming, which are dates where the FDA has to make a decision about approvals for some of these other ADC settings. So we will wait and see how these other approvals play out, and then how are we going to actually implement this for our patients. So it'll be a whole nother conversation a few months from now.
For sure. Well, that'll be exciting. Thank you so much for spending time with us today, Dr. Nunnery. This was a very informative discussion. I think something super relevant. We see a lot of patients with breast cancer, even as a general medical oncologist myself. So thanks again for joining us.
Yeah, thanks so much, Kate. Love talking with you.
Thank you so much for joining us on BackTable Tumor Board. If you haven't already, be sure to follow and subscribe, rate the show 5 stars, and share with a friend. If you have any questions or comments, direct message us at _BackTable ONC. That's _BackTable ONC on Instagram, X, Blue Sky, YouTube, or LinkedIn.
Our production team is led by Kieran Gannon,
Aaron Bowles,
Gabe D'Agrazio,
Josh Spencer, and Jaden White.
Design and digital marketing led by Brian Schmitz.
Social media and PR by Donato Cavuto.
Administrative support provided by Judy Dela Cruz.
Music by Aaron Bowles.
See you next time.